Assalamu alaikum and a very warm welcome to everyone joining us today. My name is Dr. Kanza Ahmed Chandio, the CEO of Experience Dentistry, and I am delighted to host this session of Experience Dentistry, the Forbidden Door Post-Symposium. Our focus today is on a truly important topic, behavior management dilemmas in pediatric and special needs dentistry. We are honored to have with us Dr. Tahir Shoaib, a distinguished clinician and academic with extensive training from London and Edinburgh, currently serving as the assistant professor and head of department of pediatric dentistry at Dow University. His expertise in managing pediatric and special needs patients makes him the perfect speaker to guide us through the challenges and strategies of this sensitive but vital area of dental practice. This session is designed for dental students, professionals, and practitioners eager to refine their skills in behavior management and provide the best care to our youngest and most vulnerable patients. Without further delay, please join me in welcoming Dr. Tahir Shoaib. Dr. Tahir, the stage is yours.
Assalamu alaikum, everyone. Rahim. So, my name is Dr. Tahir, and Dr. Kanza was very kind enough to give such a kind introduction about me. Okay, so without wasting time, so the topic that I've chosen today is behavior management dilemmas in pediatric and special needs dentistry. So basically, I'll be talking about the behavior management strategies in pediatrics. Though this is something very basic and simple, however, I believe that, to be honest, believe me that no matter how good clinician you are, or no matter how skillful your hands might be, if you are not good at managing the child's behavior, so all those skills go in vain. No matter how good composite fillings, composite restorations that you do, but if you just cannot manage the child's behavior, everything is in vain. So it's an important topic, and I believe all our clinicians need to be trained on how to manage the behavior of the child so that they can perform the treatment successfully. So why opt for this field? Why opt for pediatrics? So I remember our professor in England, he always used to say that, Dr. Kanza, can you go to the next slide, please? Excellent. Yeah. So why opt for this field? Why pediatrics? I still remember our professor from England. He always used to say that we as pediatric specialists, we are jack of all trades and master of the little ones. So being a pediatric specialist, it really polishes your general dentistry as well. And I can assure you that no other discipline in dentistry offers such wide variation of clinical work. And also there is a misconception in Pakistan that children up to 12 years of age are seen by a pediatric specialist. However, the age limit that comes under pediatrics is 17 years. So 0 to 17 years should ideally be visiting a pediatric specialist for the dental treatment. In pediatrics, we are doing everything that you can imagine of in dentistry, starting off with prevention, fluoride applications, fissure sealants, restorations, stainless steel crowns, surgeries, endodontics, orthodontics, and even interceptive orthodontics. So you just name it and we do it. So mastering in this field, it really polishes your general dentistry as well. And also in Pakistan, unfortunately, there's a huge paucity for pediatric specialists. So I would like to encourage more and more juniors to try and opt for this field. Unfortunately, in Pakistan at the moment, currently, we don't have specialization in pediatrics. But inshallah, in future, very soon, we do plan to start FCPS in pediatrics, so we can train more and more people for this field. And also, according to there were some stats from WHO, and they say that 47% of population in Pakistan is below 18. So just imagine that For 47% of population, there are hardly any pediatric specialists in the country. If I give you the numbers, you'll be shocked. There are only 10 pediatric specialists, 10 formally trained pediatric specialists in the country for such a huge population. Okay, Dr. Saba, can we go to the next slide, please? Okay, so we have all seen this, right, in our dental practice. So we know how children can behave. They may cry, scream, they throw tantrums and make life miserable for all of us, isn't it? However, we also know that dental treatment can be stressful even for adults, not just for children. So now the burning question is that what can we do as a dentist to make the dental treatment easier for children? So that makes us move on to behavior management. Dr. Saba, can we go to the next slide, please? Okay, so basically, what is behavior management? Behavior management refers to building a relationship between the child, the dentist, and the parent in providing the oral care for these children. And our aim as a pediatric specialist is to promote a positive attitude of the child towards dentistry. So they want to come back to the dentist again and not the other way around. I'll move forward now. Saba, can we go to the next slide? Thank you. Okay, so these are 3 terms that I've put up here. I wanted to let you know about the difference. So fear, anxiety, and phobia. So fear is basically a reaction to a known stimulus, whereas anxiety, it's a reaction to an unknown stimulus. So most of the patients, not just children, but even the adults that come to us, they have anxiety because they don't know what to expect. So it's a reaction to an unknown stimulus. And when this anxiety goes to a next level, then it becomes a phobia. So it really is possible that with simple techniques, we can elevate, we can reduce this anxiety. Okay, so let's move on to the next slide, please. Okay, so here I'll be talking about the factors that can affect anxiety and fear in patients. Again, not just child patient, in every patient. The techniques that we'll be studying today, it's not just limited to pediatrics. If you do these techniques properly, even for adults, you will be a much successful clinician. So for anxiety, we know that it's a recognized human trait. And however, there are certain factors, that can really elevate the anxiety of the patient. One of the factor is a past medical history. We've seen that patients who have had intensive medical history in the past, they normally are more anxious towards the dental treatment as well. Then the second factor is the past dental history. Children who have had previous unpleasant experience with the dentist, they are always more fearful towards dentistry. And also the parental anxiety plays a big role. Sometimes the parental anxiety can be transferred to the child. So if we assess that one of the parent is more anxious, I ask them to wait outside the waiting area and I keep the parent who is more calm and composed with the child. Otherwise, the parental anxiety gets transferred in the child as well. कितनी दफा हम देखते हैं कि mother comes into our surgery and she is very anxious about treatment and she keeps asking the dentist के डॉक्टर साहब दर्द तो नहीं होगा मेरे बच्चे को. तो बच्चा जो है, he is not listening to the word नहीं होगा, he is just listening to the word दर्द, pain. So I always tell the parents beforehand that not to use this word pain or dard in front of the child, because we don't want to associate dentistry with this term in the first place. Also, one more factor which sometimes we ignore that can lead to anxiety of the patients is the behavior of the dental staff. The dental staff should always be trained to be very welcoming, with a smile on the face. Because a rude dental staff, a rude receptionist, can immediately trigger the anxiety of the patient. Okay, so I'll move on to the next slide. Dr. Saba, shall Perfect. Okay, so let's start with the behavior management techniques. So that so the behavior management techniques, they can and should be implemented for all the patients, not just for pediatrics. So basically, I'm going to start off with the more conservative approaches, the non-pharmacological approaches that should be used for every patient. And then we are going to talk about the more aggressive techniques that can be employed in certain circumstances. Okay, Dr. Saba, please, next slide. Excellent. Okay, so the first technique in behavior management, the first thing that the patient experiences, it's something called as pre-visit imagery. So with the pre-visit imagery, our aim is to provide the child with a positive attitude, a positive image towards dentistry. The ambience and the environment of your practice should be such that the child feels welcomed. You know, your staff should be welcoming, and it should not be in a way that puts the child away. Uh, it should not put them off. Uh, and by pre-visit imagery, I don't just mean having pretty walls or having a play area, but even the staff should be very welcoming. They should always have a smile on the face when they welcome the child in the surgery. This is a picture of my practice. So as soon as the child opens the enters my clinic, this is what they see first. So it immediately calms them and makes them happy and excited that there's a play area over here. So they don't feel that they have walked into a clinic or a hospital. If possible, I would advise, encourage all the practices to have a small play area for the children. It really helps decrease the anxiety and fear within them. Can we move on to the next slide, Dr. Sarma? All right. So pre-visit imagery, it also includes, what we can do is, we can also show them some videos of children being treated very happily and very positively. So the child, while they are waiting in the waiting area, they can watch these videos, and and then they know what to expect in the surgery. It helps lessen the anxiety again. We can see here, this is again an image from my clinic. We have this, everyone has a TV display. Okay, I'll move forward from here. Okay, euphemisms and communication. Communication is really the key. Communication plays a big role, in managing the child's behavior. So we need to acknowledge the fact that the child is a 4 or 5 year old and not an adult. So the communication should always be comfortable and age related. Uh, Normally, the way I communicate with the children is, whenever they walk into my surgery, I always greet them with a high five. High five is a very universal sign. If you show someone high five, they will high five you back, right? So it immediately puts a smile on their face. Uh, Also for communication, it's always, decent way to communicate is, like, if the child is sitting on the dental chair, you should always talk to them in their at their eye level, and not that the child is sitting on the dental chair and you are standing and talking to them. You should always come to the eye level and then talk to them. Like, I normally start off with high five, then I ask their name, their age, what school they go to, what's their favorite cartoon, so things like that. But yes, communication has to be age related. Obviously, you will never ask a teenager about their favorite cartoon, right? So you need to realize the age of the patient and then alter your communication skills according to that. Also, in dentistry, we can use a lot of euphemisms. Euphemisms are alternate words for something. So I would never, whenever I introduce the child to the in the first visit, whenever I introduce them to the examination instruments, so like a mouth mirror, you can show it to them. Triple syringe can be called like a water gun or a water spray, right? Um, so you can use alternate words. For example, an etchant, I normally call it a tooth shampoo. Filling is a tooth cream. Dentistry crowns, I normally call it Iron Man tooth. So these are things that child can relate. You won't say that I'm going to place a dentistry crown on tooth. The child won't understand that. So your communication has to be according to the child's age, obviously. So you can make use of a lot of euphemisms. Uh, Let me show you another picture. Roxana, can we go to the next slide? Okay. So again, uh, so unfortunately, children nowadays they don't know about much about RoboCop, but either you can say RoboCop tooth or an Iron Man tooth. It's accepted well by especially with the boys, and for girls you can just make use of words like a silver cap, a shiny tooth. I have another picture to show you guys in the next slide. So cavities. Child doesn't know what a cavity is or what caries is, so you can make use of words like a tooth bug, like I've shown over here, so that then they know that there are holes in the teeth that have tooth bug, and it needs to be removed. Okay, I'm sure everyone has heard about this technique, Tel Shodu. It really is a very useful technique. So basically, what does Tel Shodu? You first tell the patient about the treatment. Uh, you then show them how it's done, and only then you do it in the patient's mouth. Like in this picture, we were planning to do fluoride varnish for the child. It was for a second visit. So for fluoride varnish, make use of a slow speed brush in a handpiece. So what you can do is you can first just show them the brush in their hand, give it their hand. Then you show it on their fingernail how it works. You then insert it into the handpiece, and then again you show it on their fingernail how it works, and only then you will do it on the child's mouth. So now the child knows what to expect. So the anxiety, it can really help reduce anxiety because now they know exactly what to expect, so they are not anxious anymore. This is a very useful tool. Obviously, you won't do this for adults exactly the way I told you, but it can be implemented for adults as well. Okay, let's move on to the next slide. Okay, this is also very important. Providing the patients a sense of control. So there are different ways to provide the patient with this sense of control. Um, Normally, what I tell the children is that during the dental treatment, when I'm performing the treatment, if they have any questions or if anything is worrying them, they can just raise their hand and I will stop immediately. So this gives them a sense of control that they are in control, and not the dentist. Because we as humans, we feel helpless. When we feel helpless, we feel more anxious. So now the child knows that if there's anything, if they raise their hand, the dentist will stop. And it's very important to acknowledge this, that the child, when the child does raise their hand, you should stop, uh, especially for the first 2 3 times. Otherwise, you will lose a child's trust. Okay, but then there will be some children who will just keep raising hand at everything and anything. Then you can always tell them that we're almost done, you're doing very well, and then you can continue your treatment. This you can use for adults as well. I always tell all my adult patients this, that if there's anything, just raise your hand and I will stop immediately. So it makes them feel in control. Another way of implementing this technique is by giving them a face mirror. So while the dentist is performing the treatment, they can see, they can watch what the treatment is being done. So it also helps relieve the fear of the treatment. Okay, Dr. Saba, let's move on to the next slide. Okay, so distraction. So this is again a very important technique and can be very useful, especially for pediatric patients. So in distraction, our aim is to shift the child's attention from the dental treatment towards something else. Uh, we want to shift their attention from a potentially unpleasant procedure to somewhere else. For example, in this picture, this is again a picture of my surgery. Um, I have installed a TV screen on the ceiling. So when I'm performing the child's treatment, they can just watch their cartoons. Okay, so distracts their attention from the treatment. And in the literature, there have been different techniques of distractions that have been used. One, you can make use of a video, then audio tapes. You can always give them some headphones. What else? Yes, then while you are doing the treatment, you can just continuously tell them stories and just whatever comes in your mind, just keep talking to them. So it distracts them. Okay, let's move on to the next technique that we have. Okay, so positive reinforcement and soft rewards. So by soft reward, it means that we should verbally reward the child throughout the treatment. While we're performing the treatment, we can keep telling them that they are doing very well, they're doing excellent, zabardast, and things like this. So it encourages the child to display further good behavior, because we all need encouragements. So this again you can implement for adult patients as well, not just for children. Okay, let's move on to the next slide again, Dr. Saba. No, I think we have to go one slide back. No, this one is done. The next one, please.
This
So
is
modeling.
the second.
This is the okay. Yeah, perfect. Okay, so modeling technique. Again, a very useful technique in certain circumstances. So basically, this technique it makes use of the fact that we as human we learn more about the environment from other people's behavior. So it makes use of another child of the same age or maybe an elder sibling to display good behavior. So many times siblings will walk in. So what you can do is you always treat the elder child first, and then you treat the younger child. Like even in this picture shown over here, these were two sisters, very lovely sisters coming to me. The younger one was very very anxious initially, so I first did the treatment for the elder one, and then you can see in the second picture how the elder one is helping her younger sibling to helping her for the dental treatment. She's holding a mirror in her hand, so the younger sister can watch what you're doing to her. In modeling, you can also show sometimes if if you don't have another child as a model, if you don't have another child as a model, you can always you can always make use of some pictures. You can show them pictures or videos of children who are you can always show them pictures or videos of children who are being treated successfully, and that also helps them in reducing the anxiety, and they can see that if this child can get the treatment done, then even I can get the treatment done. So it's a very useful technique. Shall we move on to the next slide, Toxaba? So desensitization, again a very useful tool. Um, this is basically it involves the treatment planning. So what is desensitization? The desensitization is basically introducing the child to new experiences in number of small stages. the hierarchy of our treatment should be such that we should start from the least invasive treatment and then go towards more invasive treatment. So this is how the hierarchy of the treatment should be, and not the other way around. Uh, I see so many dentists when the children walk into my surgery. In the first visit, the dentists have extracted their tooth or performed pulpectomy. Try to perform pulpectomy. Obviously, just imagine if you guys are a 4-year or 5-year-old and the dentist extracts your tooth on the first visit. Will you be going to the dentist again? No, at least not happily. So this really is very important in shaping behavior. What I generally do is my first visit is only consultation visit. I call it a hello visit. In that first consultation visit, I just make the child acclimatize with the environment. I will show him all the examination instruments, triple syringe, the water gun, the mouth mirror, the light. I might take some radiographs, some white wings, or I might take some photographs, but that's it. I normally don't offer any treatment, any dental treatment in the first visit. So when the patient comes in the next time, that child is much more relaxed because he has seen all the instruments. He saw that he came to the dentist. The dentist didn't do anything. It was a very pleasant experience. So then the next visit, we can always start off with prevention. Uh, by prevention, I mean we should always start off with fluoride varnishes for prevention of caries. Then you can go on to fissure sealants. Only then you go on to restorations, your ARTs, your restorations, your stainless steel crowns. And in the end, we should go towards more invasive treatments that involves uh, injecting the child, uh, pulp treatments, extractions. So this should be the hierarchy of the treatment and not the other way around. Believe me, I cannot stress enough on this slide. If you extract the child's tooth on the first visit, the child is never coming back to you, and you will spoil his cooperation for life. This is what has happened with us when we were young. Hence, everyone we have developed a phobia towards dentistry. But if you go in the right approach, in the right manner, you can successfully treat pediatric patients in your surgery. Okay, so hard reward. So we all love gifts, isn't it? Don't we? So basically, hard reward is rewarding the child with a small gift at the end of the treatment. You can always give them some stickers, balloons. I normally give them pencil, rubber, keychains, these kind of things. So this technique basically encourages the child to come back to you. So they have they have something to look forward to come back. You know, I'm sure many of the dentists over here are doing this technique. Um, all right, let's move on to the next slide. All right. So now this is a technique. I'm sure many of us have been through it. Physical restraints and then hand over mouth technique. The only reason, the only and solely reason I have put up this slide here is to educate you all not to use these techniques. Never to use these techniques. If you restrain a child physically and then perform a treatment, you will traumatize him or her for life. Okay? These techniques are strictly banned in the UK. You cannot restrain a child physically. Um, Also, this hand over mouth technique. Basically, what this technique is that you place your hand on the child's mouth, and then you calmly speak. But please don't use these techniques. We have whole lot of other techniques to use to manage the behavior, so we shouldn't be using these techniques. But having said that, we also need to acknowledge the setting that we are working in. In Pakistan, not every child can afford sedation, or not every child can afford GA. So there are certain circumstances. For example, if a patient walks in, uh, they cannot afford treatments like general anesthesia or sedation, and the child comes with a huge swelling with cellulitis, uh, or a case where the extraction needs to be done on that visit. Only then, only in those circumstances, or maybe a trauma case. A child walks into surgery with a history of road traffic accident, and for some reason you have to extract the tooth, or you have to go for emergency pulp extirpation. Only in those circumstances it is still justifiable to restrain the child physically for the betterment of the child in his best interest. But otherwise, please don't use this technique. You will traumatize the child for life. Okay, let's move on to the next slide, please. Okay, this is just so not all heroes wear cape, right? So again, this is a picture of my surgery. After we are done with the treatments, we do a small photo shoot in our clinic, and then we share this image with the patients, with the parents, and they can take this picture with them home. We print it and give it to them. Okay. So autism spectrum. So the reason I added this slide is I get a lot of referrals for children with autism. I've seen that majority of the dentists, even some very senior clinicians, they don't know how to handle these children. Um, so I want to train you guys in a way that you can handle these children in your practice successfully. So basically, what is autism? It's a spectrum of disorder. It's a spectrum of disorder. It has three cardinal features. These children have impaired communication skills. They have impaired social skills, and they like repetitive behavior. Okay, so anything that is different from routine, they don't accept it very well, very quickly. Also, we've seen that these children can be very hypersensitive to sensory stimulations. Uh, they can be hypersensitive to light, sound, uh, very importantly, taste as well. So, so these children are very challenging to treat, to be honest. And this kind of behavior can make the treatment stressful for not just for the child, but even for the dentist. So the way to manage children with autism is normally these children are on drugs, certain drugs like SSRIs or clonipramine, which are psychostimulants. So I like to and they take these medicines in the morning, early morning. So these are psychostimulants, and it helps relieve their anxiety and their OCDs. So I normally like to give these children an early morning appointment. Uh, I normally don't like them to be kept waiting in the waiting area. I take them inside the surgery immediately. Also, you should make sure that your surgery is very calm. It doesn't have many distractions. It's calm. There are no noises, because this can distract the child again and make them anxious. Also, we should try that the same staff sees them every time. Like your same dental assistant or same dental nurse is with you every time this child walks in. So so they can get familiarized with the same person. It shouldn't be such that you have a different nurse or different assistant every time the child walks in. Okay. Um, again, the desensitization technique that I talked about earlier is very, very crucial over here. I generally keep these appointments very short because they have a short attention span. My appointments are no longer than half an hour. And we shouldn't do a lot of the treatment in the same visit. Just half an hour, just do one procedure, let the child go, reappoint them. You inform the parent beforehand that they will need to come multiple times, but then slowly and gradually we can build the child's trust, and we can successfully treat them chairside in the surgery without the need for sedation or anesthesia. Um, Sometimes you can also make use of pictograms, like I've shown in the image in the slide. So these pictograms can prepare them for each step that we are going to do. Uh, Another way to treat this child is to make the child sit on the parent's lap. So they are more reassured that they are on the parent's lap, and the parent can also help us establish the communication with the child. Also, I would like to mention that since I spoke earlier that these children can be hypersensitive to noises, they don't like sounds. So we can alter our treatment in a way that, for instance, we have to do fluoride varnish or fissure sealants for them. For these patients, I don't use my slow speed brush because it creates a buzzing noise. So you can just clean the tooth surface with a sterile gauze. Um, Also, for restorations, they will not like the sound of the handpiece, the buzzing noise. So rather than going for your handpiece, we can go for techniques like ART, atraumatic restorative technique, using your hand instruments alone, because they don't produce any noise. So these small variations can help you in treating these children. These children can again be very challenging to treat. So basically, what is Down syndrome? It's we know it's a genetic disorder, trisomy 21, extra pair of chromosome 21. So children with Down syndrome, they may present from mild to moderate intellectual challenges, communication difficulties, and uh, and they really have a very short attention span. These patients can be really moody. If they're in a good mood on that day, you can do a lot of treatment. But there will be days when, if they are not in the mood, they will not get the treatment done. So we need to acknowledge this fact. Um, Also, these children have some physical characteristics like hypertonia. Then they have abnormally large tongue, and some airway considerations can also complicate our treatment. Another thing that we should be aware of is about the atlantoaxial joint. Uh, they have atlantoaxial instability, so we should really handle them with very gently and with care, so as to not to uh, damage their spine. It's very crucial. Behaviorally, they respond best to clear, simple instructions delivered calmly, slowly, and with consistency. And to be honest, if you do a lot of positive reinforcements, if you keep encouraging them to doing the treatment, uh, you follow the desensitization technique, you can successfully handle these children in your surgery without the need for any general anesthesia. Again, always make sure that you keep your visits really nice and short, not more than half an hour. Just do one treatment, one procedure, let the child go, reappoint them. So this will gradually build their trust and help you complete your treatment plan. The role of caregiver is also very important here. Again, to stabilize the child and to help establish your communication with the child. All right. So, cerebral palsy. This is again a challenging condition. So it's basically a neurological disorder. It, a very sad thing, but it actually happens due to damage to the brain during the early stages of the life. Um, it can result in motor challenges. Their muscles become very rigid. Even some intellectual problems, communication problems. Um, However, again, with simple non-pharmacological behavior management approaches, you can treat these children successfully in your dental clinic. Again, the same things, keep your visits short. They will require a lot of support positioning. So I always treat these patients while they are on their parents' lap. Sometimes we also have to treat them on the wheelchairs. You'll see a lot of patients with cerebral palsy. They'll be coming to your clinic on wheelchairs. So sometimes I let them sit over there and I treat them on the wheelchairs. Um, Again, the communication. is very important over here. You need to give slow, you need to give the information very slowly and calmly so they can process that information. And you can say words like and e. They can mimic these things, and then it will help you examine the gingival margin and allow you to have a proper full mouth examination. Like in this picture shown over here, this was a child, I believe a 5 year or 6 year old. He visited to me in my in DAW. So we can make use of mouth props, uh, or also known as bite blocks. So with bite blocks, it will help you to carry out your treatment. Like over here, we were doing a restoration for this child. We were using a handpiece. Uh, they don't have those social impairments, but again, obviously, there's they're so much challenged in so many ways. So you have to keep your appointments really short, and you have to give them frequent breaks between the treatment as well. So it demands a lot of patience to treat these children, but it's very rewarding at the end of the day. Okay, let's move on. Okay, so now we'll be moving on to the pharmacological approaches, the pharmacological techniques for behavior management. So despite of all our efforts, there will be children, despite of all our efforts, despite using all the non-pharmacological approaches that we discussed earlier, there will be children who will require additional support um, for the treatment to be done successfully. Um, for example, children, especially children who are very young, very anxious, then you might need to use these pharmacological support. It's necessary. These techniques, they range from inhalation sedation to general anesthesia, and that's how we can deliver safe and effective treatment for these children. So now let's look at the main options. Let's look at their indications and how they fit into the overall behavior management plan. Dr. Sabha, can we go to the next slide, please? All right. So these are the two main types of sedations that we make use of. One is called conscious sedation, which is also called as relative anesthesia, and then the general anesthesia. General anesthesia, usually I keep it as the last resort. When I've tried all the techniques and everything fails, only then I take the child for GA, because GA has its own risks involved. So we should try to keep it as a last resort. For sedation, we have three types. There are three ways to sedate the child to achieve the relative anesthesia. You can either sedate the child via oral drugs, you can make use of IV drugs, and then the most popular and the most safe is the inhalation sedation. So I'll be talking more in detail about inhalation sedation rather than the other techniques. So can we move on to the next slide, please? Okay, so first of all, so what is conscious sedation? So basically this technique, it makes use of drugs, maybe a single drug or combination of drugs, to produce a state of depression of the central nervous system, enabling us to perform the treatment while the child is still up. The child, it makes the child go in a semi-conscious state, but they can still respond verbally to our commands and to our instructions. So the verbal contact is maintained throughout the treatment. This is the best thing about conscious sedation. Okay, Dr. Sabha, next slide, please. I believe the next slide. It's an oral sedation. Yeah. All right. So the first one way of sedating the child is oral sedation. We can sedate them orally. The most popular drug for oral sedation is midazolam. However, for children under 12, oral sedation should not be used in a private practice. I know a lot of people who do sedate the children orally in their private practices, but this is not legal. Oral sedation should only be done by a trained anesthetist in a secondary or tertiary care hospital. So you should be having a backup. You never you never carry out oral sedation in your private practices. One main reason is that with oral sedation, the predictability of the bioabsorption and bioavailability of the drug is very it's not predictable. So you don't know how much the drug will be absorbed by the child. In UK, you cannot carry out in the primary care setting. But yes, if you do have if the child is 12 above, and if you do have a trained anesthetist, this technique can be useful. Okay, Dr. Sabakan, let's move on to the next slide, please. So the steps of sedation, it's a very simple technique. The way to do it is you first check the medical history of the child. If the child is medically fit and healthy, then you calculate their BMI, and then according to the BMI, you administer the dosage. Okay, so midazolam, it's a liquid solution. You can mix it in some flavored juice and make the child drink it with the help of the parent, and then we wait for half an hour. And during this period, we need to monitor their vital signs, their oxygen saturation. You can monitor the oxygen saturation using a pulse oximeter. And once the child is sedated, we can then start on the treatment. So this will again make the child bring into a semi-conscious state. It is helpful for certain cases, but for some, it might not work very well, to be honest. The next technique that we have is IV sedation. Oksaba, the next slide, please. Right. So IV sedation, the drug of choice is midazolam. It's the most safest and most popular drug. Again, just like with oral sedation, IV sedation should not be used for children under 12 years of age. If used, it should be done with a proper trained anesthetist and in a secondary or tertiary care. Normally, we've seen oral surgeons, they will offer you this IV sedation when you want to get your wisdom teeth extracted. So can be used for certain cases, but for children, they should be used with caution. The next technique is inhalation sedation. Oksaba, the next slide, please. Dr. Ganza, can you still hear me?
Yes, Dr. Tahir. It's on nitrous oxide.
Can we go one slide back, please?
Okay. Equipment.
Yes. So yeah. So the armamentarium for IV sedation. So basically, first thing that you need is that drug, midazolam. Then we need IV cannulas for it, and just like oral sedation, you need to monitor the vital signs throughout the treatment. And how can you do that? You can use a pulse oximeter. Okay, so you can keep monitoring the oxygen and the blood pressure of the child throughout the treatment. With IV sedation, we can reverse this using flumazenil. So if you administer flumazenil, it will be reversed, and the child will be back to normal. The next slide, please, Dr. Saber. Okay, so nitrous sedation is the most popular technique to be used in children. The reason being that it's very safe. The reversal is very quick. There are very minimal risks involved in it. And this technique you can legally perform in your private practice. So the best thing is that you can legally practice, you can legally carry out in your private practice. This makes it really safe and the most popular way of sedating the child. In the next slide, I will show you the armamentarium for it. I have a... All right. So this is the older machine that I had. But it's the most basic equipment that you can have for nitrous sedation. It's Quantiflex MDM. It's an American brand. Though I don't use it anymore. Now I have something more advanced. So basically, it has two cylinders. The black one is oxygen and the blue one is nitrous oxide. So this device, it can titrate these gases. Okay, you can control the percentage of nitrous oxide that you want to give to the child and the percentage of sedation that you want to achieve. Also, these devices, they have safety checks. safety checks in a way that just for instance, for example, in case your oxygen cylinder runs out, the nitric oxide cylinder will cut off immediately. So it makes these equipments very safe. And the maximum nitrous oxide that we can give to the child is 70%. So still the child will be getting 30% oxygen, which is we have 21% oxygen in the air. So this makes this technique so effective and so safe. But now we have better equipments. I could not add the slide, the picture of that new equipment. The equipments that we now have are they have auto calibration and they are much easier to use. They are plug and play. Dr. Sabha, can we go to the next slide, please?
Is this the slide?
This is a video. If you can play the video.
Okay.
So this
We
is the
cannot
new
see on this
device
slide,
that
so
we now
sorry about
have.
that.
Can you play this video?
No, we cannot play the video on this platform.
Oh, that's very sad.
That's all.
Okay, this
What
was
about
just a
this
video
here?
of a child getting anesthesia and extraction done while being sedated using inhalation sedation. But that's fine. Never mind. Okay, then let's move on to the next slide, please. Okay, so the indications. So first of all, the child has to be either ASA1 or ASA2. Only then you can give all sorts of sedations to the child. Okay, especially in your private practice. Then it's very useful for mild to moderate anxious patients, patients who are medically compromised. I have used this technique very successfully for children with Down syndrome, for children with ADHD, even for children with Rett syndromes. So it's very useful for these children. Then needle phobia. So we all are needle phobic, right? So it's very helpful for children who are needle phobic as well. Also, surprisingly, it works really well for cases where the child has severe gag reflex. Surprisingly, it counters a gag reflex. And as an alternate to GA, general anesthesia, it has almost all the benefits of general anesthesia, but it doesn't come with strings attached with the GA. However, there are certain contraindications as well that we need to discuss. If the child comes with nasal obstruction, they have flu, it will not work well for them. Or if the child is mouth breather, again, the gas will escape from the mouth. So it won't work very well for those children. Then there are certain conditions like myasthenia gravis, with this very low muscle tonicity. It's contraindicated for those patients. Or an extremely uncooperative child. If the child is a very young child, maybe less than 3-year-old, they will not benefit much from nitrous sedation, because for nitrous sedation, you need to understand what we're doing. We need to keep a mask on the child's nose, and they need to understand all this. In nitrous sedation, if a child is extremely uncooperative, you cannot just forcefully put the mask on the child's nose and flood them with nitrous oxide. It will not work like that. The child needs to be sitting calmly on the dental chair. He needs to have that nose piece on their nose, and it takes around 6 to 7 minutes at least for the child to get sedated. So it is very useful, but then there are certain cases where the child will not get it done. Very recently, I had a patient who was very cooperative. He got all his major treatment done, all his restorations done. I used my fast handpiece for all his restorations. He got it done successfully. But that child was mask phobic. So he did not let me keep the mask on his nose. So it happens. So then I had to perform the extractions without sedation. So there are some children and some patients, even some adult patients who are mask phobic. All right. So this is the last resort that we have. And it should be kept as a last resort. Before referring the child for GA, you should ideally try all the techniques that I explained over here. You should implement all of those techniques. If nothing works, only then the child should be referred to GA. Or there are certain cases where the child might be considerably cooperative, but we need to do a full mouth rehabilitation. The child doesn't have time, or we need to do very extensive surgeries for the child, oral surgeries. Then also we can justifiably refer them for GA. GA normally don't recommend for children who are under 4, because we need to acknowledge the fact that incubating the child is much more riskier than an adult. So normally I like to refer my patients to tertiary care hospitals for GA. Also, one more thing that I need to clear here. I know in Pakistan, there are people who have been they have GA setups in their private practices. This is illegal. This is a crime. It's a crime. You cannot do a general anesthesia case in your private practice. It has to be done in a secondary or tertiary care hospital. Normally, there are certain tertiary care hospitals in Pakistan. I'm based in Karachi. I'll normally like to refer patients to Khan or Sialteen or Liaquat. These are tertiary care hospitals. So basically, GA, it's basically a state of controlled unconsciousness. The child is completely knocked off. So it's described as complete anesthesia. Okay. Dr. Sabar, shall we move on to the next slide, please? I believe it's the last one. Yeah. So I did discuss some indications previously. So it should be reserved for patients who are extremely uncooperative. For the patients you have tried everything, nothing worked, only then GA come in. Then patients who cannot tolerate due to lack of emotional or psychological maturity, patient with certain medical disabilities, or those requiring extensive surgical procedures. And then patient for whom LA might not be effective. There are certain cases where there might be anatomical variations or acute severe infections where your LA might not work. So even in those cases, you can think of referring the child for general anesthesia. But believe me, if we do incorporate all the non-pharmacological approaches first, you can treat up to 90% of the patients in your clinic. The biggest mistake that I've seen that dentists do is their treatment planning is not right, which is very crucial. You never start off your treatment with extractions or pulpectomy. You never do that. Even if the child comes in pain, okay, first thing you do is pain management. Even if the child comes in pain, you don't need to carry out extraction or pulpectomy on that visit. You can always manage pain using medicines. You can always, Dr. Kanze, can you hear me?
Yes, I can perfectly hear you, Dr. Tahir.
Okay, yeah. So even if the child comes in severe infections or pain, we still don't need to analgesics either. Then you again come to the same treatment plan as I explained earlier. You start off with prevention. You do fluoride varnishes for the child. You do fissure sealants. You do restorations, stainless steel crowns, ARTs. Only then you should come on to extractions or pulpectomy. So this way you create a rapport with the child and you develop their trust and you shape their behavior. No one would like his tooth to get extracted on the first visit. No one is prepared for that. Even adults aren't. So we need to acknowledge the fact that we are dealing with a 4-year-old, 5-year-old. So the treatment planning really makes a big difference. I guess this was the last slide, Oksaba.
That was indeed. Thank you so much, Dr. Tahir, for being patient with us and for being very thorough with your presentation. These are literally golden points for us dentists, new grads, and the general dentists who are practicing in their clinics. बहुत चीज़ें हैं जो हमने अपने डेंटल कॉलेज में सीखी हैं, बट प्रैक्टिकली कैसे करनी होती हैं, वी डोंट नो दैट, एंड you have shown us your own examples. That is a huge reinforcement for us. I honestly had a couple of questions in my mind, but as you went through the presentation, those questions were answered for me. And I would like to ask the audience, if they have any questions, please drop them in the comment section, and we will be answering them here. In the meanwhile, Dr. Tahir, I managed to get the video that was not playing on the presentation, and I would really like the audience to see that video. If it's okay, I'd like to play it right now.
Okay, excellent. Why not? Okay, so this was, I believe, a 4 or 5-year-old girl, and we planned extraction for this child. But prior to the extraction, we had completed all the other procedures. We had already done her prevention, her facial lens, her restorations, and then in her last visit, we then planned to perform extraction. I believe it was the lower left lower left D or E, and you can see while we are extracting the child's tooth, the child doesn't even blink. Uh, so sedation can really be a very useful tool. And now this equipment is available in
Definitely.
Pakistan. So I would encourage the dentists to opt for this. And it's not just so useful for pediatric patients, but also for adult patients. We make use of this sedation in a lot of adult patients as well.
All right. And I think this is one of the critical things that a general dentist should know. And if there are courses out there, they should definitely opt for it and invest in this. Okay, I don't think we have any questions, Dr. Tahir, since you were very thorough with your presentation. Extremely grateful to you to be on our presentation, on our platform. And if you have something to say before we end, please let me know. Hello.
Dr. Sabha, thank you so much for having me here. Um, I do offer some trainings for pediatrics in my university, and we do open up internship slots. These are 2 months internship slots. Unfortunately, I cannot. I do get a lot of applications for it. I cannot take everyone in, but they can keep a check on my LinkedIn or on my Instagram page. Or on my Facebook. We do post about internship slots. Um, I'd love to train people for this specialty because I know there is a lot of paucity for this specialization in Pakistan. Uh, so anyone who's willing, they can always keep a check. Whenever we post, they can apply. I would try my best to take maximum people in that internship program.
Amazing. Well, there you have it, people. Dr. Tahir is the head of department of pediatric dentistry at Dow University. And do keep updated on his social platforms, be it LinkedIn, Facebook, or Instagram. And if you want to learn under Dr. Tahir, so that would be a great opportunity for you.
Pediatrics is a very different specialty. It's not that you just come 1 day a week and I train you. Okay. Because you need to develop that rapport with the child. So during the internship, when you are there for entire 2 months, then you can treat a patient from scratch. Then you can complete the treatment plan, and then I can gradually teach you how to shape child's behavior. It's not like an implant surgery. Just come in for a day. I teach you the implant surgery. I do a hands-on course with you, and you go. But still, in case you are interested for courses like things like dentistry crowns, lobotomies, pulpectomies, we do carry out demos for our students. So in case people want to come in, you are most welcome. You can contact me on my social platforms, and I can inform you prior the days that we are planning to carry out these demos. And people who are willing, they can always join.
Amazing. Thank you. Thank you for that invitation. Um, Dr. Tahir, this was absolutely an eye-opener presentation for me. I've learned a lot from this, especially specifically targeting the autistic, Down syndrome, and cerebral palsy patients. So, inshallah, I hope दूसरों को भी इससे बहुत knowledge मिली होगी and they'll improve their clinical work. So, with that, we will end our post-symposium of the Forbidden Doors, and I hope you learned a lot from this. Thank you, Dr. Tahir.
Thank you so much. Thank you for having me. Allah
Allah
Hafiz.
Hafiz.